Clubbing is a feature of hypoxia. So when we appose the two index fingers, there should be a diamond-shaped space in between. But in case of hypoxic adults or children, that diamond-shaped space is gone. Why? Because there is thickening of this tissue underlying the nail bed. It often occurs in smokers, in adults, smokers, and in children it occurs in congenital cyanotic heart disease. That is, the fetal circulation and the adult circulation, they are separate. They are separate. At the time of birth, once the lungs are aerated, three things close. One is there is a communication between the aorta and the pulmonary trunk. That is the trunk which goes to the lungs, and that is not aerated in utero. It is aerated after birth. So obviously that communication should close. The foramen ovale which is there present between the right atrium and the left atrium, the upper chambers of the heart, that closes, foramen ovale, and the ligamentum teres, that is the communication of the umbilical artery up to the umbilical vein to the, from the umbilicus to the portal vein, that also closes. So three things close at birth: the ligamentum teres, the ligamentum arteriosum, and the fossa ovalis. These are the three things which close soon after birth. Now, if these persist, that is, there is a patent ductus arteriosus, or there is a communication between the atrial septums, that is, a atrial septal defect, what happens? The deoxygenated blood, which is on the right side of the heart, it mixes with the oxygenated blood, which is on the left side of the heart, and that is circulated to the main circulation, that is the systemic circulation. Obviously, the child will be cyanotic. So, all cyanotic heart diseases, congenital cyanotic heart diseases, have central cyanosis. Number 2, cystic fibrosis. I mentioned earlier, those babies are suffering from gastrointestinal infections or respiratory tract infections. Their sweat chloride is increased and they have pallor, anemia, and clubbing and short height, that is stunting, in addition to these features. That is cystic fibrosis. Another is bronchiectasis. What is bronchiectasis? That is a baby who is suffering from bronchitis, that is infection from childhood. Maybe allergy is the baseline, but the child is immunologically a bit weak. Like I said about myself, that I was weak immunologically in my childhood. So Mantoux test, skin test, this, that, always all sorts of procedures used to go on. In our time, the TABC vaccination, I don't know if you got the TABC vaccination. Now it is DPT in 1.5, 2.5, 3.5 months. But we used to get typhoid vaccines through needles which were multiple punctured needles, which causes your mothers or parents, you all often see 2 marks on the arms, that is with that multiple puncture needles, that is TABC vaccine that was available at that time. So bronchiectasis is a disease which causes repeated infections. You get dilatation of the bronchial passages, and there the nidus of pus which occurs there, that causes chronic infection. Ultimately, it will cause COPD. That is, for adults also, it will be a chronic source of heart failure, COPD, when these babies grow up. Early Weezer, I already mentioned in another video, but early Weezer is a baby who has hypoxia. Then he or she may have it in the first year of life, within first 3 years of life. It may be within 6 years of life. It may be in the adolescent age. These Weezers always have some degree of clubbing because they are hypoxic. They need to take 2 puffs of budesonide and LABA before any sports activity or any activity as such. And the last is the smokers, the adults, adolescents who are smoking. They all have clubbing. You can diagnose the adolescent. Do you know, the interview with the adolescent is very, 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 very carefully you have to do it, the counseling. They get hurt very easily. Any question, any blunt question that you ask him, It will put him off. He won't answer you anything. He will look at the sky and look at somewhere else and stop answering you. So even if he stops answering you, if you look at his fingers, you can see that first degree of clubbing. You can identify that he is a smoker. And you can slowly bring it back from there. You have to slowly bring it back from there. This much only I want to say in clubbing. Next I will go to cyanosis. Now cyanosis is mainly central cyanosis which I am talking about. Central cyanosis is a feature of respiratory failure. That too in the late stage. That is, that baby will die within a few minutes. You won't even get few minutes, like severe bronchial asthma. If you don't go into injectables, you will lose the baby within half an hour. Half an hour. Not even that, 15 minutes. Central cyanosis in respiratory system is absolutely sinister. It just predicts death. Number one. Number two, I told you, congenital cyanotic heart disease, where you get clubbing, you get central cyanosis. Central cyanosis, where do you look at in the babies? You look at the tongue. Nail beds often you cannot get. Nail beds in the light, dark complexion people you cannot get. You look at the tongue. That is central cyanosis. The tongue will not be completely red or any color of red. There will be a blue shade to that red tongue, and that is called central cyanosis. That is how we diagnose congenital, chronic congenital heart disease. That is cyanotic heart disease. This is one. There is another group, Eisenmanger's complex. What is Eisenmanger's complex? In an acyanotic heart disease, we have several acyanotic diseases which we need to know, like VSD, ASD and PDA. Patent ductus arteriosus, ventricular septal defect, atrial septal defect. That in the late stage, there is right ventricular hypertrophy. The stress is on the right ventricle. The right ventricle hypertrophies, and ultimately you get the opening of the fossa ovalis, and that again mixing of the blood of the right atrium and the left atrium, and you get Eisenmanger's complex. That means that has gone to a grade 4 or grade 5. That acyanotic heart disease has become cyanotic. That is called Eisenmanger's complex, cyanosis. And last is methemoglobinemia. In this, I will tell you another story. When I was doing my post-graduation, I did my post-graduation in Patna. And there a child came to me. It was around 3 p.m. or 4 p.m. The consultant was about to leave. He was centrally cyanosed. And my consultant told me, you save this baby and you get your MD. And he went out of the room. The baby had a history of having dapsone tablets from his grandfather. Dapsone is used for leprosy. Lepers use dapsone. So dapsone was used for leprosy, and the baby took the dapsone tablets and ate it up. He doesn't know the difference. Like kerosene, they don't understand. Blue liquid, they think it is coke, they have it. And then they are in the hospitalized and all sorts of problems. So this baby, at that time, there was no treatment of this dapsone poisoning in our books. What I did was, I just used normal saline and I did forced alkaline diuresis. I just infused normal saline and I just excreted it through the bladder. Within 2 hours, I think baby was completely normal and red. So I got my MD also, at least from my guide. So I saved that baby, and this is how you should remember methemoglobinemia. That is all these drugs, that is dapsone, anticonvulsants, that G6PD deficiency, these called methemoglobinemia. So these are very important. Antimalarials, if the babies take those drugs. Now I will come to a few case studies. The first case I want to say is regarding a baby, 13-year-old adolescent, who was admitted with stunting and bilateral pedal edema. Her abdomen was absolutely scaphoid. She was very thin, thinly built, stunted, short height, and only her legs were edematous. We did a LFT, albumin was naturally less. Hypoalbuminemia was diagnosed. Malnutrition was diagnosed and due to the stunting, but we could not diagnose any disease. Baby was discharged. After a few days, baby was admitted again, readmitted, now with fever. Low degree evening rise of fever, weight loss, weight did not increase 1 kg also after that admission. That record was there with us, the previous admission. Loss of weight or not gaining weight, evening rise of temperature, history of any person taking ATD. How you ask it is, does anybody take in before breakfast drugs in your neighborhood? Before breakfast. They keep swallowing drugs. They won't tell anyone. They keep swallowing in your neighborhood. But you know, someone has drugs in your neighborhood having before breakfast. You are sure that is anti-tubercular drugs. So then we found out the root case was probably the grandmother, and she had given the tuberculosis. And she, this time radiologically, in the pouch of Douglas, that is behind the uterus, there's the pouch of Douglas. There, a small collection of fluid was there. That was taken out radiologically, and CBNAT was positive for that. So that is how we diagnosed tuberculosis in that case. So this is one case study which I wanted to tell you. Now the second case is an 18-year-old drowsy adolescent who was admitted in late evening in stuporous condition. After 3 weeks of low-grade fever, his muscle tone was increased. Plantar bilateral was extensor. Extensor means the big toe was going up. The big toe should flex. The big toe was going up. Extensor. Now, this reflex, good neurologists can easily manipulate it to get a flexion tone and or a extended tone. Anyway, we got a increased tone in the baby, and the extensor tone was bilateral. Bilaterally, it was extensor. The big toe was going up. So on fundoscopy, what we saw, there was pallor in the temporal side of the retina, temporal atrophy of the pallor in the fundoscopy. And he had a ptosis, that is ptosis, and his seventh nerve was paralyzed. What does the seventh nerve supply? The seventh nerve supplies the muscles, the buccinator, the temporalis, all the muscles of chewing and also blowing the candle. All these muscles are supplied by the seventh nerve, and it has a chorda tympani, one root to the middle ear, chorda tympani, one root to the middle ear, and it also supplies the anterior 2/3 of the tongue. The seventh nerve was affected, the right. Bilateral ptosis, that is the third nerve palsy. The left upper limb was flexed in the decorticate posture, that is only the pyramidal tract connection was lost. We have two tracts, one pyramidal and one extrapyramidal. From the cortex, it comes via the crus of the, and one is pyramidal and one is extrapyramidal. Now, when your hands are flexed to the body, it is called a bicorticate position. Bicorticate, that is, the pyramidal has gone but the extrapyramidal is persisting. And if the hands are extended and the feet are also extended with bilateral plantar, that is called a decerebrate posturing. That is, decerebrate means you are totally gone. Your pyramidal and extrapyramidal both are lost from the cortex above. That occurs only in TB meningitis. Why so? Because we get a thick basal exudate at the base of the brain with the TB organisms, with caseous necrosis of the organisms. It causes a thick exudate. And since the main cranial nerves, they are coming out from the midbrain, from the pons and the medulla, these three structures are covered by that thick pus. And naturally, cranial nerve palsies are a must in TB meningitis. And bilateral ptosis, that is the third nerve, which supplies all the muscles of the eye other than the fourth and other than the superior oblique and the lateral rectus, which is supplied by the fourth, and the lateral rectus supplied by the sixth nerve. So bilateral ptosis, seventh nerve palsy, that is the anterior taste had gone, and the baby was drowsy and in stuporous condition. And his MRI spectroscopy was done. MRI spectroscopy gives curves, lecithin and choline curves. So that MRI spectroscopy is indicated in TB meningitis. Why? Because MRI spectroscopy is non-invasive, number one. Number two is you need not do a lumbar puncture, and it gives you the curves. If you get the choline curves more, that is TB meningitis. If it is lecithin curves more, it is not TB meningitis. This is how we did. Lumbar puncture was positive for CBNAT. Protein was 200 milligram per DL. Cells were 500, mostly lymphocytes. ADA was increased. CBNAT was positive. GCS score was 7. And the fate of the child depends on the time of the diagnosis. If the GCS is more than 7 to 8, prognosis is poor. If the GCS is less than 7 to 8, prognosis is better. Treatment is with ATD for 1 year, steroid for 8 weeks, anticonvulsants for 1 year if seizure occurs. This is an adolescent boy. So 15-year-old Paul had not fared well in the pre-boards. His parents were very worried that he was bedwetting almost 6 days a month. Approach to the child, to the parents. To the child, what should you ask? Recently in gyms in Boj, one girl was suffering, an adolescent girl, 16-year-old, was suffering from fever for several days. And again a myriad of antibiotics had gone and had not responded. What I asked her was, when you laugh, do you wet your pants? The answer was yes. That is the single answer you need for chronic UTI. And I changed the antibiotic to fluoroquinolines. Second day, the fever was gone. This is how you diagnose. And not only that, the adolescent, you have to ask more things. Parental conflict. Parental conflict can lead to this. Failing in the boards, failing in the school, bedwetting, fever. I told you about alcoholic parents. I don't know if I said in this video or the previous one. Alcoholic parents, fever, vomiting, pain abdomen. These are 3 symptoms, systemic symptoms of UTI. And you get usually suprapubic tenderness and renal angle tenderness. Suprapubic tenderness is just above the symphysis pubis, and renal angle tenderness is from behind, you see, just on the 2 angles where the costal cartilage is ending, there in the angles, that is the renal angle. That is the place of the kidney. You just press hard. If it pains, that means the UTI has gone up to the kidney. So that too, those 2 will be positive. And these questions, and to the parents also you have to ask, how many sibs, gender of the child, girl child is neglected. How many sibs, if it is the middle sib, he is neglected. What sort of parent, assertive parent or guilty parent or dominating parent? Assertive parent means that you comply with your child, you give an alternative which is accepted by both you and the child. A dominant parent is that person inserts on the ego of the child, his ego on the child's ego. And guilt, emotional guilt or emotional conflict with the children. The child cannot open up to the parents. Working parent, for long hours parent is absent. So when does the parent go to office? When do they come back? Does the baby have someone to open up to? Does the baby have a grandmother or a grandfather or someone to there at home? Attitude of the other friends, sibs, friends, elders at home. Nocturnal enuresis should persist only in 5% of children. Nocturnal enuresis is not a normal phenomenon above a 15-year-old. So these are the ways you diagnose. This is the third case.